does. So when you try to do a reflex on a cadaver, and you're trying to check its spinal reflexes, well, if you base that assumption and translate that over to real people, you would say that humans don't have reflexes, right? They all have rigor mortis. So based on that theory, and I discussed this a little bit last time, one of my theories is that some of the tissues in the body, including your blood, are liquid at room temperature. And just like anything in physics, the colder you get it, the more solid it becomes. So if you heat us up enough, pretty much all of our cells will start to melt, and they'll denature, the proteins will denature. So if you make us cold enough, all of it will solidify as well. So if some of the tissue, including fibrocartilage, is a semi-solid, and it's close to solid, but not quite. So if you lowered my temperature from 98.6 down to about 60, the amount of movement there is going to be nil. And that includes, pretty much any joint in the body that we believe is fused. So the reason why they're identified as separate bones is because they're separate bones, correct? Even if they do somewhat fuse, they are still independent bones, including your cranial bones. Now, not that I treat those or adjust those, but we have to acknowledge that the ability for some movement does exist there. Like it's a plausibility. So I've actually seen people with Ankylosing Spondylitis, which is basically a disease that fuses and ossifies your entire SI joint down to your pelvis, be able to extend their hips, which would tell me there's still some movement there in either the lumbosacral joints or the sacroiliac joints themselves. So we have some ability to move those pelvic bones. So that ability to basically have a semi-solid there gives you the ability to move. And I think discs would be another prime example. Like I've cut open probably 20 to 25 cadavers. I used to TA a cadaver lab in grad school, and the discs are hard. Of course they're hard. They're room temperature. They don't have the living, breathing capacity that a human body does. There's no cellular action. There's no immune response. There's no circulation. None of that really responds the same way. And you'll see this discussed a lot. We talked a little bit last time about how people will say, like, oh, tendons are so solid they can't be damaged by human hands. They can't be disrupted or turned off. Well, sometimes it's not necessarily that we're damaging the tissue, and we don't necessarily want to, but we're basically deactivating it or trying to get the nerves to turn off. And like we said, somebody on meth versus somebody who's knocked out on anesthesia, the tissue is histologically the same, but the response of that tissue is much, much different. Some people, they could have spasms so bad they can actually break their bones. That shows you how tough muscle and tendon is. Well, we know that. That doesn't mean that you can't make a change with your hands. Does that make sense? So by using those cadaveric studies, those are somewhat helpful, but they're not really applicable to human beings. Because guess what else doesn't work on cadavers? High blood pressure medication, cortisone shots. Nothing works on it because it's a body. And a lot of new physical therapy and chiropractic graduates will try to tell you that fascia can't be denatured, that muscles and tendons are so strong that they can't be damaged. And again, my argument would be that you don't actually want to damage those, although they can be. Anybody who's ever worked on somebody who's come out of a sauna or somebody who's cutting weight or something like that, I mean, their tissue's very squishy and vulnerable at the time. Also, the colder we are, our tissues can become crystalline too because of the water cells in them. That's what happens when you have frostbite. But even before those cells actually break themselves from the water expanding, they are more susceptible to tearing. This phenomenon could be seen in stretching. So static stretching before physical activity is a no-no these days because we know what it does is it basically elongates that tissue while it's brittle and makes it weaker. So you're more likely to tear tissue and you're more likely to be injured when you do static stretching before activity. You have less force production as well. So what you want to do is dynamic, warm up and soft tissue work and rolling before activity and then static stretching afterwards. Because static stretching does have its place. We do want to keep the length of the muscles so we can have a proper length-tension relationship. We just have to know when and where to apply it. If you just got out of bed and sprinted down the street, the odds of you pulling a muscle are much higher because our body does respond appropriately, just like anything else in the universe, to heat and cold. The colder something is, the more brittle it is, the more likely it is to break or fracture. The warmer it is, the more malleable it is, the less likely it is to break or fracture. But it can also produce less force, and it can also be softer to the point where it can be cut easier too. And some of that we talked about with homeostasis is a response to our body's own ability to try to keep us warm in our core. When we're cold, we bring all the blood to our circulatory system to keep our internal organs and our brain warm. When we're hot, we actually have to keep it from overheating, so we get the blood away from the brain to the periphery, because too much heat to the inside can actually damage the brain, can damage internal organs as well. A prime example of this is males with their testicles. So when it's hot, they move away from the body so we don't damage sperm. When it's cold, your body retracts them in to try to keep them colder so the sperm don't die from being too cold. Because we have a very specific temperature range in which we function optimally. All of our cells in the body have different temperatures at which they function optimally. So that's why I always laugh when people are talking about like colonizing Mars and stuff like that. I'm like, come on, man. Like, we are so married to this planet. We can't go anywhere without the microbiome here. I mean, we are one with this planet. You're not going anywhere. We can't live on Mount Everest. You can't even live in the water. Like you live on a beach house, like you're living next to certain death. You cannot survive, and that it's pretty and everything, but you don't have gills. You might be able to swim for a little while, but you cannot live there. That's not for you. You can't live on Mount Everest. It's not for you. You cannot survive there. You cannot survive in the Sahara Desert. Those are not places for our frail human bodies to survive. And that's on the planet, by the way. That's here. Much less millions of miles away. Which always kills me when we want to explore other planets. I'm like, we have a lot of work to do here, guys. Like, all that money we could sure use towards, pick one, ending wars, feeding the homeless, cleaning up the environment. And now I sound like a hippie, and I'm really not. But as far as a logical perspective, like, where should we be spending our funds? That sounds fun and everything, but how many space missions do we really need? What is that really going to do for us? Everything that affects us is here. I mean, the odds of we're not going to find some cell on Mars that's going to give us everlasting life. More than likely, even if we did come across some other microbiome out there, our systems aren't equipped to handle it. It would probably kill us all. You guys remember, what was that movie? Not Mars Attacks, War of the Worlds, where they evaded us, but their immune systems couldn't handle our bacterial populations. I mean, think about what happened when the Europeans came to the Americas. And it's the same species on the same planet. But because there were variations in the disease states, they completely ravaged certain populations of people because their immune systems weren't ready for it.
If you go to Mexico, I'll bring some of my friends down there and they'll eat some of the food and, they're not used to the bacteria.
Yeah, mess you up.
Yeah.
Certainly. And keep in mind, you have more bacterial cells in your body than your own cells on the surface of your skin and your gut. All right, so back to the bones of the pelvis and the hip. So the argument can be made, we talk about the pelvic complex. So we're going to talk about the sacrum, the ilium, the pubis, and the coccyx. Okay, we also have the ischium. Those are considered distinct bones. I would argue that they function more as one unit in a human adult. So we're going to teach pelvic movement and theory in certain spaces here. So in traditional chiropractic and naprapathic theories, and even PTs, you can go so far down the rabbit hole that you'll be so confused that you have no idea where to start. So if you start thinking that I can have a right external pelvic flare, okay, then what happens to the femur? Does it have to internally rotate to compensate for that? And then what happens to the tibia? And then down the road you go, and then you never know where to start. So if your pelvis rotates this way on L5, does L5 go with it, or does it stay where it is? So that's what I'm going to try to simplify for you guys a little bit here. You always want to, so Occam's razor is the simplest answer is most likely the right one. Of course, that's the most likely. That doesn't mean that it's the only answer, but you always want to start simplistically here. So the way that I'm going to teach it is in three ways. One is going to be in a uniform way, basically that the pelvis moves as one unit. That it could either rotate right to left relative to the L-spine or relative to the femurs, right? Because we have to talk about relativity here. Okay? Or I can tilt this way or some combination of those two movements. So that would be if all these bones were fused together. So the sacrum, the ilium, the ischium, the pubis, were all functioning basically as one functional unit. So muscles would basically cause those to rotate, right? So looking here, let me slide back a little bit. So if I had a right QL spasm, for example, that would draw the ilium up and posterior on that side slightly, which would draw it slightly relatively down and forward on the other side. That would give me a presentation like that if I had one muscle that was firing unilaterally. Okay. If I had a right hamstring cramp, for example, it attaches on the ischium, it would cause a slight posterior tilt on that one side, which would give me some combination of that movement. Not acknowledging the ilium that can move independently, which I'm not saying they can't. I'm just saying in this case we're going to act like they don't. I'm also going to teach one that basically acknowledges that it does too. So we talk about the the other part of the pelvic complex is going to be the actual hip joint because it ties into the pelvis itself. So the acetabulofemoral joint is the actual hip socket. So we've got the acetabulum, the acetabular labrum, so that gives you depth and allows the femur to sit in there. It gives it some depth to the joint. The femoral head, and then the ligament of the head of the femur, which is actually where you get the blood supply to the top of the femur. So anybody remember Bo Jackson? Football player, he had his hip replaced. So he was running down the field, and somebody grabbed him by the back of the foot, and he basically dislocated his hip temporarily. Went right back in. But what happened was he tore the ligament to the head of the femur, basically disrupting the blood supply to the head of the femur. So he got avascular necrosis on the top of the femur, basically ending his career. He had to have a hip replacement. He was the first NFL player to play in a game with a hip replacement, but a player that his game was predicated on speed was never the same. And that's why you have to be careful. So like a lot of people like to do a lot of like leg pulls and distractions like that. It's very easy to damage that ligament. So if you're going to do that, you have to make sure the depth is incredibly small, like less than an inch, because that's about how long that ligament can stretch. So if you pull somebody's leg that far, you're putting them at an exponentially higher risk of tearing that ligament and basically putting them on the road to a hip replacement.
I was talking to somebody this past weekend that their chiropractor tried to do that to their friend and totally just dislocated.
Yeah. So you have to keep in mind that every intervention you have has a negative consequence as well. So you have to weigh those things against each other. And anytime you're doing high velocity thrusts, your risks go up a lot. So when in doubt, you want to use lower velocity movements. When you combine high velocity and high amplitude, the rate of adverse events goes through the roof. So a high velocity, low amplitude thrust, that's a fast but very little motion, right? That's designed to create joint motion. So if you do a high velocity, high amplitude thrust, now you're taking that joint past its own range of motion, which can damage ligaments, arteries, and really hurt people. You can also do a high amplitude, slow motion as well. Make sense? But you're better off with both of those two things being less, generally speaking.
Could inversion mess up the ligament?
It could, but usually it's going to need more force to it to do that, like a snapping type force. So in Bo Jackson's case, he was running full speed, somebody stopped his leg from moving and pulled it apart. Or in the case of physical therapists and chiropractors, yanking in the leg really, really hard and really, really far can certainly damage the hip. Okay, so looking at the sacroiliac joint. So the sacroiliac joint is the combination of the ilium, which are the wings there, right, and the sacrum itself. So it's a synovial joint. It does have synovial fluid. It's made up of fibrocartilage on one side, a different type of cartilage on the other side. So what you're feeling there on the back there is going to be the PSIS. That's the posterior superior iliac spine. That's the part you feel on the top that sticks out. Most of the time when you have these presentations, you'll feel one that's more prominent than another when you're looking at sacroiliac joint dysfunction, which is one of the very most common causes of lower back pain. So looking here on this x-ray, you can see the SI joint. It's visualized very well there. Do you guys see that? You can see it very well here. So in somebody with ankylosing spondylitis, essentially what happens is that joint disappears. It becomes ossified. It's one big chunk of bone. You can also develop arthritis there as well. So that can be pretty bad too. So we can see that we have a disc here in the front where the pubic symphysis is. That's another joint that's capable of motion. So we have the ligaments of the pelvis and hip. So unfortunately, and this is what makes Naprapathy special, is that we understand ligaments, right? So most people will view the spine, particularly in the chiropractic and PT world, like it just sits there like that. But that's not true at all. Ligaments are all across, particularly in the spine, that hold everything tightened together. So as you can see here on the posterior aspect of the pelvis, there's a ton of ligaments there designed to check motion. Meaning that in a normal, healthy person, there shouldn't be a whole lot of motion there, even if the bones themselves are capable of moving. Look at all those ligaments, right? So we have the sacroiliac ligament, the posterior sacroiliac ligament, the anterior sacroiliac ligament, the iliolumbar ligament, which, by the way, can certainly influence lower back pain if it becomes taut. The sacrotuberous ligament is a big one as well. So as you can imagine, it connects the sacrum to the tuberosity. We have the sacrospinal ligament. We have tons of ligaments in there, right? We have the articular capsule, capsule of the hip joint, and that's that ligamentous tissue around the hip there. That can also be damaged with too much distraction force. All right, deep muscles of the pelvis. So these are the ones we were talking about before, the glute medius, the piriformis, the gemellus superior, the obturator internus, the gemellus inferior, and the quadratus femoris. All right, you also have the adductor magnus, the hamstring part, and the adductor part. So the adductor magnus has two parts that function the same way. So the hamstring part is going to be a knee flexor because it does cross the knee joint and ties in downstream. So does the gracilis, right? And a lot of times those aren't discernible when you're looking at a cadaver. They are kind of blended together. And then you have the femur there. So the greater trochanter is where a lot of times we can have bursitis. That's the part that sticks out right there. So a lot of times people will talk about they have pain deep in their hip joint and they touch the greater trochanter and they go, it's right there. Well, that's not in their hip joint. When somebody truly has hip issues, you're going to feel it a lot in the groin and back on the other side as well. If they're pinpointing there, what you may be looking at is bursitis of the hip or maybe a small tear of one of the muscles that attaches on the backside. Particularly glute minimus and glute medius are susceptible to tears there, especially in the elderly. And you can see the piriformis kind of attaches more over the top. See that? So these three ones right here are the ones that we're worried about, the small tears. So the obturator internus, we think, can sometimes provide internal rotation, sometimes external rotation. It depends on where you are. Quadratus femoris right there, that's a big one for me. So a lot of times people will have a really tight quadratus femoris, and they will try to raise their leg up, but their hamstring won't be tight, but the motion that presents as a hamstring, like touching their toes or lifting their leg up, will present like it's tight, but they'll feel it in their butt or their hip, not in their hamstring. That's one of the clear indicators to me of the quadratus femoris, maybe the offender there, is you can see its attachment from the ischial tuberosity to the trochanter. If it's too tight, it won't allow it to turn. So no matter how much they stretch their hamstring, it never changes. If somebody tells you that, that's a good sign that it's not their hamstring. Make sense? All right, and so down there we can see the piriformis, the gemellus superior, the obturator internus, the gemellus inferior, the quadratus femoris. Those muscles are all down really deep and low in the gluteal area. And these are the ones that nobody ever talks about. People are obsessed with the piriformis, glute medius to a certain extent too, but these other ones also have a value and function as well. So we can see the line of force that they pull on right here, the glute medius. That's going to be more of an abductor of the hip, so it's going to bring your leg more to the side. What's the prime abductor of the hip?
Is it glute? Glute max.
It's glute medius.
Glute medius.
But glute max is also a very strong abductor of the hip. The glute max functions a little bit more in extension and also external rotation. If you look at the fiber angles, it does provide a help into abduction as well.
More external rotation.
Yeah. So when you see people sit down on those machines at the gym, the Sharon Stone machine, all right, you're not that. I always got to check the age of my class when I say that one. So they'll call it the abduction machine, but it's not really abduction, right? Because they're bent at the hip, that is not abduction, that's external rotation. So imagine if I extended my spine up and we did that same motion, it's external rotation. Pure abduction has to be done with the knee straight. I mean, I suppose it could be done, but it's hard to do. You almost need to lock your knee out to be able to abduct the leg. Okay. The adduction is more internal rotation, but there is some adduction as well. You'll hear me say adduction, AD, right? So it adds to the center line of the body. Abduction moves away from the center line. So adds brings you to the middle if you guys are having a hard time with that one. Okay, so piriformis is right here. You'll see the sciatic nerve goes underneath it. In a certain percentage of the population, I believe about 18% or so, it actually goes through the belly of the piriformis itself. So those people can be more likely to have sciatica symptoms, true sciatica symptoms, if their piriformis gets tight. In the regular population, if the piriformis gets tight, it can compress the sciatic nerve as well at the sciatic notch. Now this is pulled apart, so you can see the the gluteus minimus underneath there. It serves in a very similar function to glute medius, just a slightly different angle. So we got a lot of butt muscles there, right? Okay, flipping back to the front here so we can see the 12th rib here. So the QL attaches from the top of the ilium to that 12th rib, so it gives us lateral motion. It gives us resistance to lateral flexion to the left. Eccentrically, it gives us concentric motion to the right, particularly the initiation of the movement. People that have chronic lower back pain will have something called fatty infiltration of these muscles. So essentially what will happen is their body will it'll marble the muscles, so it'll be full of fat because it's not being used. You don't use it, you lose it. On MRI, we'll actually see a difference in the size of people's QLs and psoas majors from side to side. And it'll usually correlate with the side they have more back pain on. They'll have atrophy of the ipsilateral psoas major. So we're looking more here. So we have the adductor group here. So that's magnus, gracilis, and several other adductors. When you're treating adductors too, you want to be basically moving their leg into external rotation, and you'll feel which one of these muscles is limiting you, and you'll treat one of them, you'll move it a little further, you'll find another one, treat it, move it a little further. So when you're looking at this picture right here is really great for treating adductor muscles because it gives you a nice visual representation of where the adhesions are. So here, here, here. Okay. We have Sartorius, so it attaches from the ASIS all the way down to the pes anserine, which means what? Goose foot. Yeah. It's just the shape of it. So it's a common attachment point for 3 muscles there. Anybody know the 3 of them?
3 attachments to where?
The pes anserine. There's 3 muscles that attach there.
They're all adductors?
Nope. So you're gonna.
Lateralis.
Nope.
Or
Sartorius,
oh, okay.
gracilis, and semimembranosus, but not tendinosus.
Yes, there's a surgeon. No?
Hmm?
There's like an acronym to remember those.
Oh, I don't know.
Is it SGT, so Sartorius tendinosus?
Yes. Sartorius, gracilis, membranosus.
Membranosus.
Excuse me, I'm wrong. Tendinosus is correct. Tendinosus is correct. I apologize. It is tendinosus. So Sargent, maybe?
Yeah, SGT.
I've never heard that.
Yeah.
And eventually you want to get to the point where you just memorize them instead of having acronyms, but those can be certainly helpful as you're starting to memorize them.
Yeah.
When you get into clinical practice, they're a lot easier to remember because you're treating each one individually, so you have to know what to look for. Right now it's theory, so acronyms can help you guys get through classes. So looking here, we can see the iliacus, rectus femoris. There's 5 quadricep muscles underneath there, all innervated by the femoral nerve. I'll give them to you guys. Rectus femoris, vastus intermedialis, vastus lateralis, vastus medialis, or vastus medialis oblique, so you'll hear people say VMO. VM is fine. I don't know why we need to throw obliquus in there. There's a muscle that lies underneath those as well. Okay, it's called articularis genu. It doesn't show up in textbooks, but its job is to move the suprapatellar bursa out of the way during knee extension. The reason why that's burned into my memory is my first boss, my first day on the job, we have a group there, and he looks at me and he goes, "Hightower, you're a genius, right?" So I'm on the spot, right? Like a no-win question. So if you say yes, you're an arrogant prick. If you say no, then I don't know what I'm talking about. But he basically gave me that question. He said, so what's that muscle that lies underneath the quadricep group that's innervated by the femoral nerve that moves the suprapatellar bursa into extension during knee extension? Of course, I never learned that in school. But there's a muscle called the articularis genu that lies there, so I've never forgotten that. And emotions typically will help you remember things, like it or not. All right, so then we have our vastus lateralis and the IT band, which sometimes can blend together on people. You'll hear a lot of people saying the IT band doesn't have contractile tissue. I can certainly assure you that it does. And think of it as an abductor of the hip as well. It's basically the common tendinous attachment from the TFL and the glute maximus, which both tie into that IT band. It's just a long tendon. So you'll hear a lot of new age people say, don't roll your IT band, blah, 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 blah. We've demonstrated over and over again using stim with electricity that the muscle contracts, and we've deactivated it and made huge differences as well. I've treated IT band syndrome for 9 years the exact same way and have a 98% success rate on it. You just strip it, man. We can needle it too, but generally speaking, most IT band syndromes, as long as there's not bursitis involvement, will respond really, really well to manual therapy, which would not occur if it didn't have contractile tissue. Okay. The other thing to think about too is like a lot of people with massage backgrounds or things like that tend to not think of us as damaging the human body when we work on people, but 100% every time we work on somebody, we're creating inflammation, we're creating damage itself. Like on a chemical level, we're literally moving molecules and ions off of the top of it, right? Much less actually histological damage, which we are creating by pressing on stuff and breaking cells. That's why sometimes they bruise. That's why sometimes when we have gua sha, we break the capillary beds. All of that in the hope that you will create a inflammatory response for healing. So if you have the ability to hurt somebody, you can hurt them too much as well, and that's important to recognize the difference. So one of the big things we see out there in the field is people getting too much body work, too much deep tissue work. So we have to recognize the summation of the amount of force on the body. So if I'm getting a foo-foo massage, I'm getting just a light, massage, I can get an hour and a half and not be that bad off. But I've seen people get like 2 people on them with elbows and they feel sick afterwards, they throw up, they get a fever, and people will say, oh, those are just toxins being released from your body, which isn't true at all. You don't store toxins in your muscles. That's not how the body functions, okay? Our body has detoxifying systems. We have the liver, the kidneys, the gallbladder. We have a lot of systems in place to basically deal with that, the lymph system. So when somebody's feeling sick after deep tissue work, there's a reason for that. It's because we've damaged the muscles to the point where there's free myoglobin in the blood system. And your kidneys are having to deal with that. So really, a person can only deal with about 15 to 20 minutes max of really deep tissue work. Anything more than that, and you're flirting with rhabdo. So rhabdomyolysis is a condition where we break our muscles down to the point where our kidneys start to shut down. You will experience fever, flashes, nausea, throwing up, and it can be fatal. It can put people on dialysis. It's not a joke. This is the most common in the CrossFit community now, particularly the hero WODs. The Murph is the one that's most notorious. I can't remember, it's the Memorial or Veterans Day. But basically what they do is 100 push-ups with a weighted vest, 200 pull-ups, 300 air squats, and they run a mile before and after with a weighted vest on. And so a lot of these people aren't really that fit, so some can do it, especially if they're on, anabolic steroids and things like that. But the average person isn't capable of recovering from something like that. And so every year we see 3 or 4 cases of rhabdo come into the office. We have to send them to the hospital right away. Their urine will usually be brownish because they've broken their muscles down so much. But I have seen patients that have gone to deep tissue therapists that have presented with the exact same symptoms. You can do it to yourself by doing too much lacrosse ball stuff too. I've known patients in the past that have spent 3 hours rolling out over the course of a day. That's way too much. Think about if you brush your teeth for 3 hours, what your gums would look like. It would be a problem. So there's, more is not better, better is better, right? So it's important to get people efficient to where they're not doing too much. The total duration and force into that, if it's hard, can only be for so long. So the amount of force in one of my treatments, which is about 10 to 15 minutes with a deep, I'm going pretty hard, is about the same as maybe an hour and a half of like a Shih Tzu, or not a Shih Tzu, it's a dog, a Shiatsu, or some other type of massage. So the cumulative input to the body is about the same, but you cannot do the same duration with the same force. Things break. And unfortunately, some people don't understand that concept, and they just keep hammering and hammering and hammering. That's not necessarily a good thing. And by the way, you can tear muscles. I've known people that have torn patients' rotator cuffs and things like that before. So particularly with pin and stretch type motions. When they stick their thumb in the rotator cuff in the back and they move the arm in and out, I mean, you can imagine physically how that's possible, right? If they already have a framed or a partially torn infraspinatus tendon, now I pin it and then I force the motion, you can certainly make those tears worse. Where generally speaking, myofascial work is going to work really great, right? It's going to deactivate the muscle, it's going to recruit an inflammatory response, right? So you're going to have cytokines, prostaglandins, arachidonic acid, all of your mediators of inflammation, which, by the way, your body has to have. I know we're in a society right now that's obsessed with inflammation, right? But you have to have inflammation to heal and to survive. Your muscles don't recover if you don't have inflammation. That is a natural response to your body. Now, what's not a natural response to your body is autoinflammation, where your body attacks itself for no particular reason, particularly food input and things like that. So it's appropriate to have inflammation to injury. That's how your body heals. If you don't have that, that's a problem. But autoinflammation is not necessarily a good thing, and we're seeing a massive spike in it right now, right? We don't really know why. Is it the antibiotic input? Is it the food? Who knows? But we are seeing a massive spike in it. And we're thinking that a lot of different disease states are related to autoinflammation, including heart disease, maybe autism, tons of gut inflammation problems, Crohn's, ulcerative colitis, MS, HLA-B27, that's AS, ankylosing spondylitis, rheumatoid arthritis, and it appears that Alzheimer's has an inflammatory component as well. That's why we think that people that consume turmeric more may have less inflammation on their brain, which leads to Alzheimer's. So inflammation, systemic inflammation is bad. Localized inflammation is actually good. Does that make sense? So we actually need that to be healthy and to respond appropriately So when somebody has something happen and they take ibuprofen or aspirin, they're actually slowing down their healing response, like if they twist their ankle or something. So you would actually want maybe to recommend Tylenol or something that's more of an analgesic and less of an anti-inflammatory to help with the pain, but not necessarily slow down the healing process.
Can a disc regenerate? Disc from the vertebrae?
Yes.
Okay. So can you cause an inflammation response with a high velocity adjustment to help regenerate?
No, probably not. So in a healthy person, you should not be able to move one of their vertebrae relative to another one. They're connected by fibrinogen that basically connects the disc to the bone. There's also a massive amount of ligaments holding it in one place and muscles as well. So in a healthy person, vertebrae should not move independently. So I tend to subscribe to the theory that you cannot actually move one vertebrae laterally or whatever in the absence of massive pathology, which could be the case on a disc herniation or something like that. Unfortunately, medically, that would be a contraindication to high-velocity manipulation. Now, could there be some level of tilt due to ligament tightness and laxity on one side? Yeah, that's possible. But usually they're going to go in a sequence, like 3 of them will be moving together in one tilt as opposed to one just offline. There's some exceptions because there are some that move independently, like C1 and 2, and then maybe your lumbosacral junction. T1 is also somewhat unique because of its vertebral attachments. It has ribs that attach to it that don't necessarily attach by a joint in the front. So if those ribs move, they can force that vertebra to move independently relative to C7 and T2. So like all rules, there's exceptions. And there are people, like we said, with connective tissue disorders that are going to actually have the capability for those things to move independently. But in a normal, healthy person, you shouldn't have individual vertebral movement. Like you shouldn't have an L4 going to the right, relative to the rest of them. Like our spine is more stable than that, generally speaking. Like it should be much more resistant to forces than that. Okay, so looking at the thoracolumbar fascia, and cross crawl, these are our posterior patterns here. So we can basically see how the forces are transmitted through the posterior aspect of the body. Your left lat is going to transmit force through the thoracolumbar fascia to the right glute max and then down the posterior chain and vice versa. This gives what's called a cross crawl motion. So when you're walking, your right arm should go with your left leg and vice versa. So we have a sling that basically gives us force that rotates us, especially as bipedal animals. If you have a disruption in that, whether it's lower back pain or a lat problem or a shoulder problem, you could have any of the following. You could have shoulder dysfunction, back pain, or it could throw your gait off, which can lead to knee issues, feet issues, and other problems. So we can see that line right there, right? Pretty nice straight line. Kind of makes sense to everybody. And we think this probably comes neurologically from our fish days or crawling days. It also gives us balance. If my right arm goes to my left leg, it keeps me centered, or I'm less likely to topple over. The less likely I am to topple over, the more likely I am to have intercourse and pass my genes on to the next generation, which is the purpose, right? So anything that's going to make you susceptible to damage is something your body's going to not want to do. And so we play on that, right? Like we talked about before, like all a knee reflex is a protective motion. If you miss a step outside, instead of falling and cracking your skull open, your muscles should jolt to try to protect you. You guys ever miss a step? And you don't get a chance to think about it. You got that, all your muscles spasm up. Or an elevator that drops or whatever. So that's basically a reflexive response, trying to proprioceptively put you where you need to be in space. So when I hit you on the knee tendon, basically what I'm doing is I'm tricking your body into thinking that muscle's too long. In its response, the quadricep contracts to try to find its space. We don't have a chance to think about it. It happens in the spinal loop. It's like stepping on something sharp. You pick your foot up off the ground to protect you. You don't get a chance to think about it. If you touch something hot, your hand comes back. Our body has built-in protective mechanisms. When we push on a muscle belly, the opposite happens. If I press on the quad, basically I'm tricking the body into thinking it's shorter than it should be, so I created a new attachment point in your brain. So instead of at the patella, the stop point is where my finger is. Neurogenically, your body will deactivate that muscle to try to elongate it to find its set point. That's one of the main mechanisms in how connective tissue or soft tissue work works. When you hold a trigger point down, that's the main methodology of how it changes. You've now tricked your body into thinking that muscle is too short. Neurogenically, it now elongates the tissue to try to get to its normal resting position. It turns it off from the inside out through the sarcomere. At that point, then you could actually stretch it. Where before, if the muscle was bound up in the center, All the stretching would do would make the tendons pull on the bones at the periphery, potentially causing what's called apophysitis or insertional tendinopathy because it's just yanking on the bony attachment, which is why soft tissue is so beneficial prior to stretching. Kind of makes sense?
How does it look on, connective tissue and basically how everything works as far as the trigger points and,
I'll have to think about that. Not off the top of my head.
We had one for connective tissue, but it's too tedious and everything wasn't really organized.
Right. And some of them can be like too histologically focused, to where they don't really connect to the big picture very much. There are some other mechanisms in which soft tissue works as well, including, what's the word? Thixotropic activities. So thixotropy is the viscosity of the tissue itself, which the connective tissue has to some extent. Like it has a viscous amount that can be actually smoothed out. Muscle has that to a less extent. Fascia and tendons have it to a more extent, where you can actually remodel fascia and tendon a little bit more than muscle. Muscle is much more contract, relax. That's what it does. All right, so 7 joints in this region. We have the lumbosacral, the sacroiliac. We have 2 of those, of course. Sacrococcygeal, the symphysis pubis, and the true hip joints. 2 of those, hopefully. Sacroiliac joint is mostly classified as a freely moving diarthrodial joint. The sacral surface is covered in hyaline cartilage, and the iliac surface is covered in fibrocartilage. Synovial fluid is found within the joint cavities. So synovial fluid is incredibly viscous. It's the most viscous material basically you'll ever touch in your life. Way more so than WD-40 or oil or anything like that. It's incredibly slippery. So if you ever really want to mess with somebody, pop one of your gang that says get that synovial fluid, rub it on the floor, and somebody will slip on it and fall. Studies of cadavers, that's kind of gross. Studies of cadavers show that males have less motion than females, and the SI joint begins fusion of males around the age of 40, and nearly all are ankylosed after that. Females show motion in the pelvis up to 50 and 60. I think I misquoted that earlier. I apologize. And rarely ever show fusion. So, and I'd have to check that fact too. Most surgeons will tell you that the female pelvis fuses. And of course, biologically, we would say the reason for that would be pregnancy. That's why the females have more ability to create pelvic motion. The pelvis needs to be able to open up when somebody's pregnant. That's why we have hormones that basically relaxin and others that cause the ligaments to lose their tensile strength and loosen up. So we have nutation and counter-nutation of the sacrum. So nutation and counter-nutation, right? You guys remember those? So nutation is going to be that anterior portion. So if this was the sacrum, counter-nutation is going to be that way. The average degrees, this is like kafif, right? The average degrees of change is 2 to 3.5 degrees, according to Campanji, etc. Nutation nodding is when the sacral promontory moves inferior and anterior, while the distal end and coccyx move superior or posterior. Counter-nutation is when the sacral promontory moves superior and posterior, while the distal end and coccyx moves interior and inferior. Those are terms that you don't really use in clinical practice. If we were going to use the terms nutation, counter-nutation, those would go hand in hand with tipping in a monoarthrodial model, meaning that we didn't think that any of those joints moved independently. I would argue that you don't really see a lot of true nutation, counter-nutation. The reason being is that the L5 disc doesn't allow that. If you create too much of that, you will damage the disc, and maybe that's the reason why we see so much L5S1 disc degradation in humans. For too much forced nutation, counter-nutation through trying to move the pelvis back and forth, particularly weighted. Ligament laxity and stability, so the importance of the ligaments in the sacroiliac joint, so the sacrospinous, sacrotuberous, posterior sacroiliac, anterior sacroiliac, anterior longitudinal ligament, those are all relatively important structures there. Pregnancy causes the release of the hormone relaxin that causes the ligaments to elongate, allowing for expansion of the pelvis for childbirth. Relaxin secretion ceases after lactation stops. Approximation could be asymmetric after relaxin ceases, resulting in low back pain and dysfunction. Does that make sense? When we have relaxin, it literally does allow the pelvis to move in an independent fashion all the way through the end of lactation, right? So what does that mean? That's not after birth, right? Right, which can go for a long time, depending on who you're talking to. Some people breastfeed for a long time, years. So that being said, there's still going to be the ability to dislocate all the joints in the body, not just the pelvis, shoulders, ribs, all kinds of things like that. So essentially, anybody who's lactating essentially has a connective tissue dysfunction waiting to happen. The connective tissue isn't solid, and so they have subluxation and dislocation, basically waiting to happen. They're much more highly movable than a normal person. And that's part of why pregnancy is a differential for almost any kind of disease. We talk about preeclampsia and things like that, like blood pressure changes. Tons of different diseases. They can look like that, but they're pregnant. Which is wild to think about, right? Like it's like this other human being is now a parasite living inside of me and using all my nutrients and causing my entire abdomen to expand, and then it has to come out of this small hole that it really wasn't biomechanically designed for. Oh, the things we do, right? We're wired for it. That's why we're all still here, right? Because all of our mothers thought that was a good idea. Or maybe we're forced into it or talked into it, All right, symphysis joint. So the symphysis pubis, the sacrococcygeal joint, the intercoccygeal joint. So those are all basically symphysis joints. The pubic symphysis is the best example of that. So it has a little disc in it. It can potentially move side to side, but generally speaking, it should move offline in the absence of relaxin or disc derangement. Normal ambulation, we should be able to achieve 40 degrees of extension and flexion from toe off to heel strike in a healthy hip. Inability to do so can have an external or internal rotational factor due to the need to create more distance. So I'll let you guys kind of look at that when I send it to you. We can have anteversion or retroversion of the femur itself in the socket. So anteversion is medial rotation of the femur. So it's going to have rotation relative to the pelvis and tibia. This results in medial knee movement and pes planus. So pes planus is a flat foot. This fixation will also create a functionally shorter leg. So if that happens, it's going to move the femur slightly forward, which is going to tilt more of your body weight over it. Retroversion is lateral rotation of the femur relative to the pelvis and tibia. This results in lateral knee movement and arching of the foot. A functional longer leg will be apparent. So this will give you a longer leg, which will give you a posterior tilt and sacroiliac joint dysfunction on the longer leg side. Hidden hip muscle information. There are no prime internal rotators of the hip. Fibers from the TFL, glute medius, adductor magnus, and gracilis affect internal rotation. Arguably some of the gemellus muscles as well, and the internus muscles as well. Roughly 1/3 of the glute maximus muscle inserts into the IT band, so the TFL is not the only muscle that may potentially need to be addressed when assessing IT band dysfunction. Lying TFL stretch. So here's an example of how to stretch the TFL. Okay, some ways to strengthen the iliopsoas. We could do eccentric strengthening. So I would argue that most people's psoas isn't really tight, it's actually weak. Also, I would argue that you cannot touch the psoas major because it's so deep, it's behind the internal organs completely. So when people say they're releasing the psoas, oftentimes, in my opinion, they're releasing the obliques and the rectus abdominis and maybe even the transverse abdominis, which all will give you positive clinical results. But for some reason, we want to attribute it to the psoas. I would argue if you wanted to get to the psoas, you'd be better off almost trying to scoop underneath the QL from the posterior aspect if you really wanted to release it. But that being said, oftentimes you're going to have one psoas that's stronger than the other. So if we had a weaker one, how could we strengthen that? Well, maybe eccentric strengthening. So doing like a slow drop from a leg raise position to try to elongate it but make it stronger. And eccentric strengthening has the most amount of impact on muscle. So if you want to make a muscle stronger and longer, eccentric is the way to go. It's also the force or the phase of muscle strengthening that's most likely to cause an injury as well. So we have to keep that in mind. Although without weight and using your hip flexors, you're unlikely to get injured here.
Case like snappy hip syndrome,
Mm-hmm.
would you want to strengthen the psoas or would you want to release it, or would you not really want to follow it?
Probably strengthen it, just to try to get a tighter hip joint, because there may be too much femoral movement in it, but there's not really an answer. Like if you look at the research and even the clinical stuff, I've never really known anybody who was just amazing at it. And as long as it's not painful, it's nothing I would worry about. Most people have a hip that snaps, particularly the right leg. Most people have an externally rotated right femur. There's many theories for this short leg syndrome. Some will argue that because we're right-handed, that we used to stand on the left leg to throw a spear. I would argue that it's probably because we drive cars. So we push that femur forward all the time, then we externally rotate it to go from gas to brake.
How about kids that are born breech, right? So they have a disadvantage too because their hip joint isn't as formed.
Yeah, So a lot of times that'll present with like dysplasia. So they don't have enough depth to their femoral joint, which can certainly lead to early arthritis. It can also lead to extra force being placed on their sacroiliac joints because their femurs don't move as much. That answer your question?
Yeah. I have one that, my last one was born breech, so
Mm-hmm.
it was abnormal, but they didn't have to do anything special with him.
Does it have a tight hip?
I don't know.
So you have to find out if there's a problem. So keep in mind, like I wouldn't really generally treat anything that isn't causing pain or problems. That's my philosophy in my office, and other people don't deal with that. But I generally don't treat people that aren't having it interfere with their life in any way. I know that it might in the future, but if somebody comes in with no pain, there's only one way to go from there, right? Like I can make them worse. I can't make them better than good. So I don't treat people that don't have a problem. So you have to identify a problem first. Once we identify that there's pain, then what we have to do is decide if they have too much motion, too little motion, and then assess it from there.
One last question. So in your clinical experience, like, what do you see more? Posterior on the right side or on the left side?
Probably I find more posterior tilt on the left side. Probably 2 to 3 times more often. Same thing with sacroiliac joint dysfunction. Probably 2/3 of people come in with left sacroiliac joint dysfunction. So they have a sharp pain right on that PSIS. That's where the lower back pain starts from, and then it emanates to the rest of their back. But one of the reasons that I find that to be the case, and we will correct that positionally too, is my theory is this, is that what happens is the right lower glute muscles, the piriformis, the gemelli, those ones we basically use too much on the right side. So eventually what that does is it limits the movement of the right sacroiliac joint. So the left one is moving relatively more than the right one. Eventually that extra motion creates so much motion that it gets a posterior tilt or whatever, and then it irritates the tissue. So we get a ligament irritation and then a spasm. And that extra motion is what causes the spasm. So oftentimes if they have a left posterior sacroiliac joint dysfunction, if you treat the right lower glute, you'll get a lot of change out of it. So that you'll free up that right side so they're relatively moving more equally. Everybody wants to go to the symptomatic side, but it doesn't really help that much. So for most people that have left sacroiliac joint dysfunction, by doing lacrosse ball or medicine ball or having somebody work on their right lower glute, that usually gives them the most amount of relief.
It's like the opposite, you know what I mean?
Get a lot of different opinions.
Yeah.
Glute medius, so one of the tests that we can do there is a standing leg raise, Trendelenburg. So Trendelenburg sign, basically, if you stood on one leg, your glute medius was weak, you would have a hip drop on the opposite side. You can see here the glute medius on the right side was weaker. We wouldn't be able to maintain the pelvic position. You're generally not going to see that in the absence of pathology, nerve damage, some sort of trauma. All right, so glute medius, it's the prime abductor of the hip. It crosses the trochanter and is often a culprit of greater trochanteric bursitis because of where it attaches. It's innervated by the superior gluteal nerve, internally rotates the hip during hip extension. It externally rotates the hip during hip extension, and it creates a net neutral motion, aka prevents internal rotation. So it prevents excessive internal rotation. All right, Trendelenburg sign, if the left leg is elevated, the right hip falls, right glute medius is positive for weakness, that's a positive Trendelenburg sign. Most, generally speaking, and these are generalities, most people are going to be kind of weak on their glute medius because we don't ever abduct our legs. We're also going to be weaker in abductors in the shoulder too. Our lats are generally going to be tighter than our deltoids. Our adductors will limit abduction. If my adductor is too tight, then I can't spin the femur in the socket the right way. So when I abduct, it'll basically force it to run into the hip and create FAI potentially. Or it'll decrease the max power in my abduction. So if somebody was trying to get their abductor stronger or bigger, what you'd want to do first is to roll out or loosen up the adductor so you can get the max potential out of that, both from joint movement and muscle activity. So if you're going to work out, you're better off, you want to roll the muscle you're going to work to, but you're better off actually rolling the antagonist so you can create optimal activation in your agonist. Okay, piriformis. So the piriformis can create an inflamed sciatic nerve, basically pinching on it like we talked about before. Iliopsoas, the combined muscles of the iliacus and psoas major, primarily composed of slow twitch stability fibers, are tasked with axial compression of the lumbar spine. The combination only exists at the femur, and the muscles are distinct as the psoas major and iliacus in the abdomen. Also, we have a psoas minor. So you can see a cadaver here. Here's our psoas major. You see how far posterior that is? In order to touch that, you've got to go through the colon, through the small intestines, which I would not recommend because you can cause a perforation and you can kill somebody. So if I run at an axis that you can kind of see what I'm talking about, here's the QL. So I would almost want to try to scoop through the backside if I really wanted to get to the psoas major. Does that make sense? And keep in mind, we're layered in muscles, right? So I can't get to the piriformis without going through the glute max. So if I was worried about deactivation of my glute max, I wouldn't want to treat the piriformis because I have to go through it and I'm applying more pressure to the superficial layer than I am to the deep layer to get through it. Does that make sense? And pretty much everywhere in our body's that way. Like, we tend to not think of it. We imagine these muscles aren't there, that we're like going through it or swimming through it or whatever people will tell you. But you're pressing on that muscle. And it's always going to be more force superficially than deeper. It's simple physics, right? Same thing in the shoulder. Like, these aren't sexy muscles like treating glute max or deltoid or rectus abdominis. It's much more fun to tell people we treat the iliopsoas and the piriformis and the infraspinatus because it makes it sound cool and unique. But I promise you, like, sometimes treating these big muscles, you'll get way better clinical outcomes than people that are chasing after the small ones. Like, most of these are stabilizer muscles. They're not really prime movers. You know, if you're having problems moving, what are the odds that it's a prime mover that's your problem? Pretty high. Not necessarily a stabilizer. If you're having a hard time stabilizing, then you may be having a problem with your stabilizers. Does that make more sense? I mean, and, you know, these are just not the way that people think about things. Whether it's professors or clinicians, they don't have a way to bring common sense back to the table. They learn the textbook stuff and they basically regurgitate what they were told. And if somebody questions them, their brain kind of short circuits. And they're like, oh, I don't know, maybe that might be true. I'll have to think about that. They go, no. Rah, rah, rah. Rabble, rabble, rabble. In you know, anytime you can put together a cogent argument for something, I mean, you have to accept that as a possibility, right? But if you can't do that, then I don't know where to start with you. If you're just saying it just is, that doesn't really work very well for me. It probably doesn't work very well for you guys either. You probably wouldn't be in this program if you were a strict by-the-book person that we just do everything that we're told. You're probably a little bit outside-the-box thinker, and you're probably a person that questions things. So, all right, so the psoas also flexes and laterally rotates the thigh. It attaches at the disc level from T12 to the disc of the lumbar spine with the exception of L5S1. It can contribute to the contractures, particularly in the elderly and sedentary. So if it is too tight for too long, it can cause a contracture. So it can contribute to those super old people that are kind of stuck forward, even though it's supposed to create lordosis. If it's held there for long enough, it won't create lordosis anymore. It'll just drag forward. Part of that is because we'll compensate by extending the T-spine to try to get upright, but it doesn't really work because your facet joints are in the way. We can't actually extend the T-spine. You can extend the thoracolumbar junction, but again, you're going to wear out the posterior elements. Okay, Ankylosing Spondylitis, there's a test for that. It's called HLA-B27. HLA is human leukocyte antigen, so it's a blood test. So if you suspect it, it's found mostly in young men. They will have ongoing posterior sacroiliac joint dysfunction and stiffness. So it is an autoimmune disease. Some of the signs you'll see railroad sign or bamboo spine. And I'll pull up a picture for you guys so you can actually see what a skeleton looks like in somebody that has AS. It can be debilitating. They do have some medications that can slow the process down these days. Athletic pubalgia, that's called a sports hernia, which isn't actually a hernia. It is inflammation or irritation along the joint line itself, particularly right on the pubic bone. We think it may be caused by microfraying of the adductor tendons. It could be caused of synovial irritation of the ligaments or of some of the structures that go to the gonads. We don't really know, but it's not a hole in the intestinal wall like a regular hernia. All right, let's take a break.